Hello guys, I'm Dr. Sajad Pathan and today we are going to look at some images which can come in your exams or you can come across them while you're practicing in the emergency department. So without wasting further time, let's look at the first image over here and you can pause the video and give me your diagnosis. So the diagnosis over here is anterior plus inferior wall STEMI and this patient needs to go to the cath lab. Okay. The next image is over here for you all to look at. The diagnosis over here is inferior wall myocardial infarction, inferior wall STEMI, and the treatment over here is same. A patient goes to cath lab. Some articles do mention that giving GTN in inferior wall myocardial infarction is contraindicated. However, recent articles have said that it is safe, but for the exam purposes, I would avoid GTN. Again, you can pause the video here and give me your diagnosis over here. So here, if you look at the septal leads V1, V2, V3, there is an ST depression, and if you flip the ECG, you will be able to record the ST elevations on that side. That's a posterior wall STEMI, and remember, posterior wall STEMI, posterior wall is supplied by RCA, right coronary. You need to take posterior leads like V7, V8, V9, and you should also take the right-sided leads. Again, this is a very classical exam-oriented ECG, and I have come across a couple of patients in the last few years. This is D Winters T waves, and this is equivalent to a anterior wall STEMI. The lesion over here is either in the left main or proximal LAD. So the patient goes to the cath lab and treated accordingly. There are two things in this image. One is the rate is quite fast and it's irregular. So this is atrial fibrillation. I can't appreciate P waves properly. In addition to it, there is an inferior wall MI. If you look at lead 3 and AVF, there is an ST elevation and there is reciprocal ST depression in the lateral leads and AVL. So this is inferior wall MI and atrial fibrillation. If the patient is this patient is unstable by definition, so this patient gets cardioversion, which is synchronized. So this is classical ventricular tachycardia. Again, if there is a pulse, the patient gets synchronized cardioversion. If there is no pulse, the patient gets defibrillation. This patient has been on PPI for a while and now he comes with palpitations. So we all know PPIs can induce hypomagnesemia, and hypomagnesemia can prolong QT and can give rise to torsades. This patient, if there is a pulse and patient is stable, you need to start magnesium infusion and you need to prepare for synchronized cardioversion. This patient has come with a syncopal event and you notice that the heart rate is pretty slow. So that this is a classical complete heart block. The initial treatment is atropine, atropine, atropine. However, most of the time it doesn't work. While we are waiting for transcutaneous pacemaker, while we are waiting for a proper pacemaker, we can do transcutaneous pacing. And if there is an infectious etiology related to complete heart block, think of Borrelia burgdorferi, Lyme disease. Now this ECG is quite often tested in the exam. You will come across them while you are at work as well. If you closely look at this ECG, there is a left axis deviation and there is a right bundle branch block and there is prolonged PR. So this is a trifascicular block. If it's not recognized and treated quickly, this patient can go into complete heart block. This is Sgarbossa criteria for a left bundle branch block. There are modified versions available, so have a look at it, and it's not that difficult to understand. If you see ST elevations in V5, V6, that is a STEMI equivalent. If you see ST elevation in V1, V2 more than 5, that is a STEMI equivalent. If you see ST depression in V1, V2, V3, that is a STEMI equivalent. This is a 14-year-old guy who's come in with collapse, and what you see is sharp dagger-like Q waves, and what you also see in addition is kind of a left ventricular hypertrophy. So whenever you come across a syncopal patient with LVH and sharp Q waves, think about hokum, and please do not label these ECGs as a left ventricular hypertrophy. This is hypertrophic obstructive cardiomyopathy. This patient is coming with chest pain, and you get this ECG. If you closely look at the septal leads, there is a biphasic T wave, and this is very classical of Wellen's syndrome. And this patient is similar to De Winter's T waves, either a proximal LAD or left main lesion, and this patient needs to go to the cath lab. This is a patient who has a strong family history of sudden cardiac death, and this patient has come with a collapse. Yes, you guessed it right, it is Brugada syndrome. If you look at the septal leads, you see that RBBV kind of picture, and you need to differentiate this from Wellen's. Wellen's is coming in with chest pain, Brugada is coming in with syncope. This is another 14-year-old guy who's come in with syncopal event, and you see those waves just at the end of QRS in the septal leads or in the limb leads. You will see them very classically, and this is arrhythmogenic right ventricular dystrophy. These waves are called as epsilon waves. This patient needs to be admitted. Okay. This is a dialysis patient who's missed his dialysis and is coming with palpitation. He looks unwell. What is the next thing to do? The next thing to do is give calcium gluconate. The next thing is not VBG. Next is calcium gluconate, and then you can wait for the VBG to come back and reverse the hyperkalemia. There are tall T waves over there. And while if you see this patient and you are waiting for confirmation of potassium through the VBG, the patient goes into this rhythm, and this is called as a cine wave pattern. This is severe hyperkalemia, and this is too late to diagnose this patient. This is a patient who was at a party, had some nitro poppers, and come in with shortness of breath, and you guessed it right, that's chocolate colored blood. That's Methemoglobinemia, and treatment is methylene blue. This patient is coming with a head injury, and clear fluid is dripping from his nose, and you found it on the bedsheet. This is called as a double halo sign of CSF rhinorrhea. Here you see ecchymosis around the eye, that is called as raccoon eye. Ecchymosis at the mastoid, that's battle sign. And you also see the tympanic membrane, which is having blood behind it, and that's hemotympanum, and this is classical of fracture base of skull. This is a guy who's coming with a painless loss of vision, and the fundus is shown over here where there is some pale retina, cherry red spot, and the diagnosis over here is central retinal artery occlusion. It is a painless loss of vision. This is central retinal venous occlusion, called as blood and thunder image of the fundus, again painless loss of vision. This patient is coming with abdominal pain, vomiting, and headache and loss of vision. If you see cloudy cornea, which is mid-dilated and fixed, that is acute angle closure glaucoma. You need to know the drugs that can precipitate glaucoma. So mid-dilated opaque pupil, painful loss of vision, vomiting, and abdominal pain. Treatment is pilocarpine, mannitol, acetazolamide, timolol, and definitive treatment is iridotomy. This patient comes in with complaints of curtain coming down, and that is retinal detachment. That's the ultrasound image of the eye, and if you look onto to the left side over here, that is the vitreous over here. That's vitreous hemorrhage, and if you look at this image, that is your retinal detachment. Okay. This patient is coming who looks very, very unwell with loss of vision, painful eye, and you notice some whitish pus in the anterior chamber, and that is your hypopyon from iritis. And these patients need to get systemic antibiotics and should be referred to ophthalmology immediately. Again, another scenario, there is no pus in this, but this is again iritis. If you look at the pupil, it is irregularly shaped. That is because of the synechia formation, and there is also episcleritis in this image. That is your sclera bulging out because the sclera is inflamed, and this is scleritis. This is a patient who's come with herpes zoster lesion on the forehead, and you did a fluorescein staining of the eye, and you see these pretty looking signs on the cornea. That is your dendritic ulcers. These patients need systemic antivirals. This patient is come with painful loss of vision or blurriness of vision. Likely there is a foreign body under the upper eyelid, and it is causing corneal lacerations. That's called as ice rink sign. This patient was doing some work, and some foreign body went in the eye, caused the puncture wound on the eye, on the cornea. And if you see, when you put in fluorescein, it is dripping back into the anterior chamber. This is called as a Siddle's test, and Siddle's test is positive. That is your eardrum, rugby player or a boxer who comes in after an injury, and there is blood collected in the external ear. This is auricular hematoma. Need immediate aspiration or incision and drainage, and pressure dressing to be applied, otherwise they will get cauliflower ear. This patient has come in with loss of hearing. When you look into the ear, you see the tympanic membrane is perforated. Treatment over here is reassurance and asking them to keep it dry. It usually should heal in about 2 months' time. You can get them reassessed, and if it's not healing, they will need surgical treatment. In the exam, if you see somebody with an open mouth and they are showing you a tongue depressor looking at the cheek, try to look for your white spots on the cheek on the inner aspect, usually unvaccinated kids. This is measles. Those are Koplik spots which are pathognomic, and you get to see cough, coryza, conjunctivitis, Koplik spot. This is a notifiable disease. Okay. If they're showing you a tongue, that is strawberry tongue. This is Koplik spot. This is not strawberry tongue. That is the ultrasound image of abdominal aorta, which shows an aneurysm over there. This is an ultrasound image of your fascia iliaca block anatomy. This patient is come in with a collapse, and when you look at the echo bedside, you see a completely collapsing LV with fluid around it. This is tamponade. This patient is come in with abdominal pain, red currant jelly stool, and that's ultrasound image, and that is your intussusception. So on the left side, there's a normal looking lung. where there is seashore sign. On the right side, there is a barcode sign. That's your pneumothorax. Be careful interpreting the pneumothorax in terms of bulla. The bulla also looks like a barcode sign. So if whenever in doubt, get a CT scan to differentiate between the two things. Thank you for watching this video, and I will soon come up with part 2 so that we can make this EM images kind of video series, so that it will be easy for you guys to revise at the last day. And do consider subscribing to the channel, or hit that thanks button or the join button to join the membership of the channel and help us grow. Happy studying. Peace.